Today, we have Dr. Katie Suda, who is going to talk to us about antibiotic prescribing. Dr. Suda is an alum of Drake University. That's where she got her PharmD. She got her master's degree from the University of Tennessee. She did a PGY1 residency. I'm going to remember all this. She did a PGY1 residency in Memphis. I don't remember the institution. Then she came here to UIC to do a fellowship. She worked with the infectious disease faculty, Keith and Larry, here at UIC as part of her fellowship. She then took a faculty position back in Tennessee while she was also completing her master's degree in epidemiology. Katie eventually decided to move back to Chicago and is a senior investigator at the Hines VA and an associate professor in the Department of Pharmacy Systems, Outcomes, and Policy. And she is going to wow us with the impressive work that she is now doing on antibiotics, and I don't know if she's going to talk about opioids too.
Wow, thanks for that, Todd. Todd is also an illustrious alumni from Drake University, Des Moines, Iowa, in case you all don't know where that is. All right, so thank you, Todd. So I have no conflicts of interest in relationship to this presentation. I am receiving funding for my research from several different federal sources, which are highlighted on the slide. And I specifically want to point out the funding for the research that I'm going to present today, which is an R01 from AHRQ, and 2 different VA merit awards. So Todd asked me to speak today at seminar today to give you a little idea of my path to my current work that are focused on dentists. And the way he asked me was really funny because he knows that I actually do not like going to the dentist personally. My dentist lives in my neighborhood, and just seeing him walk his dog makes me sweat. And then he also asked me to talk a little bit about how this area fits in my overall research program, as well as some of the impact of my research. So he wanted me to talk about all that other stuff that I do. So I know there's a lot of trainees in the room today, so I'm going to tell you a story that makes it appear as if my research has followed a straight path, a direct arrow. But in reality, my research hasn't always followed a direct path. I haven't always been in a research-intensive role. I've been in a medication use policy and patient safety role in the past. And I think that that's really helped me to make sure my research impacts patient care, but it's also given me unique opportunities to do some of the health policy work that I'll talk about later today. But I do want to note there's always been one consistent theme, and that is the treatment of infectious diseases. So what am I going to talk about today? I'm going to focus on outpatient antimicrobial pharmacoepidemiology. And I've published a lot of papers in this space, and if I don't talk about the paper that you and I published, I'm sorry, of course it's my favorite. But I'm focusing on the work that either informed health policy or built the infrastructure for the R01 and the Merit Award that I'll talk about later today. I'm not going to talk about some of my work in the epidemiology or the treatment of multi-drug resistant organisms. I'm not really going to talk about opioids today. We've been on an opioid theme, so I thought I can always come back and talk about that later when we have a little more results. And I'm also not going to talk about our assessment of health policies. So this talk is focused on a body of work. So it's not a methods-focused talk on one particular analysis, but I know many of you are interested in methods, so feel free to ask me later. I'll also present some preliminary results on the R01 and the merit, and then I'll end with the impact of my research. Now, because I'm going to talk about 15 different papers today, I'm going to be skipping around on the data source that we use. I think you're all familiar with most of these data sets, with maybe the exception of IQVIA, which is formerly known as IMS Health. So those of you who have worked with Dr. Cato, she also uses IQVIA data sources. Just know these data sources are population level. They're at least 90% of the universe of prescription drug use or prescription expenditures. And then the other thing to know is the VA pretty much has any quantitative variable that you may be interested in from about 1992 to present day, so a lot of different data sources. So what's the problem? Why am I speaking to you today about antibiotics? Well, antibiotics are not safe drugs. They're a common cause of visits to the emergency department, especially in children. And antibiotics are the single most modifiable risk factor we have for the development of resistance and the emergence of C. difficile infection. And every hour of every day, 3 persons in this country die from an infection caused by a resistant organism, and an additional 3 persons die from C. difficile. And that's equivalent to deaths secondary to opioid overdoses in this country. Now, I know what you're all thinking. Well, these patients are sick. They're in the hospital. They're in long-term care facilities. And while that once was the case, the majority of resistant infections and C. difficile actually now occur in the community. And this is increasing logarithmically. And we're increasingly seeing young, healthy persons, such as yourself, acquiring these infections, and they don't have traditional risk factors for multi-drug resistance or C. difficile. So what can we do to modify these trends of decreasing multi-drug resistance, C. difficile, and improve antibiotic prescribing? We can prevent infections by preventing the spread of infectious diseases by implementing effective infection prevention strategies. The most effective is simply washing your hands, which we can all do. We can also do surveillance on antibiotic susceptibilities as well as circulating viral strains to help us in guide prescribing. And we can also track antibiotic prescribing at the national level as well as at the local level. We can develop new drugs as well as diagnostic tools. And we can improve antibiotic prescribing by clinicians and use by patients. And strategies to improve antibiotic prescribing and use collectively are called antibiotic stewardship. So the question was, is the 5th eating at a certain restaurant chain but has had some listeria outbreaks recently? And I plead I probably no comment, but the best is to probably eat at places that you feel safe eating at, that have a cleanly environment. But I have to say, I do really like that restaurant. But in Thailand, I did avoid street food. The other problem compounding all of this is that there is currently a lack of drug development, specifically for antibacterials that treat multi-drug resistant gram-negative rods. We've had a couple successes lately, but novel antibiotics with novel mechanisms of actions to combat resistance are really lacking in the drug development space. So we need to use the antibiotics we have now judiciously. And in order to improve antibiotic prescribing, we need to know how and why antibiotics are being prescribed. So in the absence of aggregated prescription data across the U.S. healthcare system in the various sectors, we use expenditure data as a proxy for use. And we found that 60% of expenditures were in the community or dispensed from outpatient healthcare settings, and about 1/3 were from acute care. Now, this was a bit surprising to some because at the time that we published this paper, the vast majority of stewardship efforts were actually focused in the acute care setting. Now, we've compared these data to European countries where aggregated prescription data across healthcare sectors are available, and we actually estimate that about 80% of antibiotic consumption occurs in the community. And this one little paper, which Glenn and I recently just published an update, this one little paper, very simple descriptive analysis with some bivariate statistics, has really been the primary driver that you're seeing behind the increased emphasis in outpatient antibiotic stewardship. Now, I'm not going to talk much about antifungals today. They are an important part of providing antimicrobials to our patients, especially immunocompromised patients. But antifungals, we also published this paper last year with my VA postdoc leading this with Dean Schumach and I. And we also found some surprising trends. So these are systemic antifungals, and we were surprised to see that almost 40% of antifungal expenditures were in the community as well. And this is becoming increasingly important because more and more patient populations are indicated to receive empiric antifungals. Just think of the number of patients in the community who are immunocompromised currently today. And similarly, this paper is being used by the mycotic branch at the CDC to encourage stewardship programs, especially in acute care and long-term care, to include antifungals in their appropriate use campaigns. So this was the first step that I needed in order to identify the gap in evidence in the R01, that the majority of antibiotic consumption is in the community in the United States, but there's very few efforts ongoing to improve antibiotic prescribing in the community. So we know the majority of antibiotic consumption occurs in the community, but let's talk a little bit more about the antibiotics prescribed. So annually in the United States, about 260 million antibiotics are dispensed for oral antibiotics. And this translates to 830 antibiotics per 1,000 population. Or said another way, 5 out of every 6 U.S. persons receives an antibiotic annually. And this is a lot of antibiotics, especially when you compare this population-based rates to rates in European countries, where the rate is 200 to 300 prescriptions per 1,000 population, 1/3 that of the United States rate. I also want to mention that we saw significant geographic variability with the highest prescribing rates in the southern United States. West Virginia was the highest overall, and the lowest rates in the western United States. And West Virginia had twice the rate as Alaska, which had the lowest rate in the United States. And this is similar to what we see with resistance. So the highest prevalence of resistance is in the south, typically, for almost any organism you want to look at, and the lowest is typically in the western United States. So again, this was another key piece of evidence, is that we see higher antibiotic prescription rates than other European countries, and that this is likely an indicator that there's a lot of overprescribing occurring in the U.S. So we also did a multivariable analysis to identify predictors for oral antibiotics in the community, and we found that counties with a higher proportion of obese persons, children under the age of 2, women, and persons of Black race were more likely to be in the highest quartile of at the county level for antibiotic prescribing. So that was just 1 year of data. So if we trend the data over time, we are seeing some decreases in prescribing. So the primary y-axis here is your population-based prescription rate, and it's also shown in red. And then the secondary y-axis is the raw number of prescriptions in millions, which is shown in blue. We're seeing about a 6% decrease in antibiotic prescribing annually, which is definitely good. But one thing I wanted to show, if you change the scale of the y-axis to be a little bit closer, we are seeing some variability, such as some small increases, such as in 2009 during the H1N1 pandemic, and also in another year where there was a poor match between the circulating influenza strains and those included in the influenza vaccine. So we're going to talk more about seasonality in a few minutes, but I wanted you to look at this over time as well. So who are prescribing these antibiotics? Well, the majority, over 75%, are prescribed by physician providers. But if you break this blue section of the pie down further, 24% are prescribed by family practitioners, 12% are prescribed by pediatricians, and 12% are prescribed by internists. And the majority of outpatient stewardship efforts that were occurring on the national level, such as providing resources, were focused primarily on these three physician types, these primary care providers. Now, the next group were actually dentists, and dentists prescribe 10% of all antibiotics in the United States, just behind pediatricians, which are considered a high-volume prescriber for antibiotics. But we know very little about how or why dentists prescribe antibiotics. And of course, we'll talk a lot about that later in the presentation. Now, antibiotics prescribed by nurse practitioners and physician's assistants, about 6 to 7% of all antibiotics annually. But the amount of antibiotics prescribed by these advanced practice providers are increasing, likely due to the increased prescribing autonomy these professionals have received by the states, as well as the new models of healthcare delivery in the outpatient space, such as retail clinics, which are predominantly staffed by nurse practitioners. So overall in the United States, the number one class prescribed are for penicillin-based agents, which is shown in this graph in the dark gray section. And amoxicillin is the most frequently prescribed agent overall. And this is closely followed by the macrolide class, which is shown in the diagonals. And azithromycin is the most frequently prescribed agent, just following amoxicillin. But azithromycin is the most frequently prescribed agent to adults. And the key thing here to know is in the outpatient space, we consider macrolides, which azithromycin is a macrolide, and quinolones to be broad-spectrum agents. So physicians, nurse practitioners, and physician's assistants prescribe very similarly. Penicillins most frequently, followed by macrolides. But we're increasingly seeing advanced practice providers prescribe these broad-spectrum agents. And this is concerning because broad-spectrum antibiotics have the highest risk of resistance and C. difficile infection. Now, this paper was the first paper to actually describe what antibiotics dentists were actually prescribing. And they have a very different profile than the medical providers, where the majority of antibiotics are for penicillins, which are considered, most of them are considered relatively narrow spectrum. Amoxicillin was the majority of these medications. I think about 65% of all these medications, antibiotics prescribed. But the second most frequent agent prescribed was clindamycin, which is shown in the black and white checkerboard in this graph. And dentists are the top prescriber of clindamycin in the United States. And we are very concerned about prescribing of clindamycin because historically, Clinda has had the highest risk of C. difficile infection and has equivalent, in one dose of Clinda, has an equivalent risk of C. difficile as a prolonged course. So here's another key piece of information that I used on my pathway to focus on dentistry, is that dentists prescribe 1 of 10 antibiotics in this country, and they prescribe very differently. So I alluded to earlier that we see some seasonality. So if you compare the prescribing in the winter over the summer months, you will see an approximate 20% increase in antibiotic prescribing in the winter over the summer months. And that's because seasonally we see more respiratory tract infections in the winter months. But the majority of these respiratory tract infections are viral in origin and do not require treatment with an antibiotic. So we stratified this by provider type, and on the y-axis here is a provider-based prescription rate, and on the x-axis is month and year. We saw the highest seasonality actually for nurse practitioners, which is shown in the yellow dots here, with a 34% increase in antibiotic prescribing in the winter over the summer, followed by physician's assistants, and then followed by physician providers. We saw very little seasonality for dental providers, which is what you expect. But interestingly, we just completed an analysis with Express Scripts data, which is a national PBM, and found that if you stratify dentists by their specialty, we actually did observe some seasonality for orthodontists and pediatric dentists. And we're not exactly sure why, but we're looking forward to teasing that out further. So looking at seasonality can give us a little bit of a clue of inappropriate prescribing, but really we need to be able to associate a diagnosis with a prescription. So we use the National Ambulatory Medical Care Survey and the National Hospital Ambulatory Care Survey to estimate the prevalence of inappropriate antibiotic prescriptions in primary care medical visits and ED visits. And we conservatively estimated that at least 1 in 3 antibiotics prescribed in these primary care medical encounters are unnecessary. Again, primarily prescribed for acute respiratory tract infections. We also looked at respiratory tract infections where an antibiotic is sometimes indicated, such as pharyngitis, which is sore throat for you non-healthcare professionals in the room, sinusitis, and otitis media, such as otitis media is ear infections, and we excluded our sample for that to children. And we found that in those infections, half the time, antibiotics were inappropriately selected. Typically, a broader spectrum agent was selected than treatment guidelines indicated. So I mentioned that this is a conservative estimate, and that's because advanced practice providers, there was not a sufficient sample in the data set. We also didn't have specialty providers such as ENTs. We did not have urgent care visits or retail clinics, and we also did not have any data on dental providers. Now, this outpatient data suggests 30%. Other outpatient data suggests up to 50%. And in acute care, it's estimated that half of all antibiotics are inappropriate. So antibiotic or antimicrobial expenditures are one of the top expenditures that we see in our United States healthcare system. And some years, antimicrobials even trump antineoplastics. So just think if we could just decrease antibiotic expenditures by 30%, just a little bit of what's inappropriate, we could decrease drug expenditures by about $3 billion. So this is a big deal. Okay, so let's talk a little bit about dentists. I'm starting to sweat just thinking about going to the dentist. So what do we know? First, dentists prescribe 1 out of every 10 antibiotics in the United States. Guess what else they prescribe 1 out of every 10? Opioids, right. So dentists prescribe antibiotics, we think, just based on their scope of practice, from the treatment of oral infections and the prevention of distant site infections. And no one had data to estimate the proportion of how many antibiotics were prescribed by dentists for either treatment or for prevention. So why did dentists prescribe antibiotics for prevention? Well, certain patients have high risk of what we call distant site infections, such as infective endocarditis, which is an infection of the heart valve, and infection of prosthetic joints, such as if you have a knee replacement. And when these patients go to the dentist and they have an invasive dental procedure, bacteria is introduced into their blood, which we call bacteremia. And certain patients have a high risk for this bacteria to then seed their heart valves especially. But guidelines have narrowed the indication for prescribing antibiotic prophylaxis prior to a dental procedure because the evidence has shown that very few patients have an increased risk of these distant site infections over their normal daily oral hygiene, such as brushing their teeth. And we don't ask these patients to take an antibiotic every time they brush their teeth. But since these guideline changes, we've only seen a very small decrease in dental antibiotic prescribing. And these guidelines started changing about 10 years ago. So we also know that there's limited prescribing resources available to dentists. There's a total of 2 sets of guidelines. So if you look at primary care providers, there's probably, 20 or 30 sets of national guidelines for them to use. In addition, data on prescribing by dentists in the United States is scarce. We didn't even have an overall profile of medications that are prescribed by dentists, and the data sets available also are not that plentiful, to be honest, to do this research. And health services research in dentistry is extremely limited. So here's another key. Limited prescribing resources for these dentists, as well as limited pharmacoepidemiologic research has been done. And that helped me identify the gap in evidence. So at the VA, we wanted to guide some of our research efforts, but also our efforts in targeting antibiotic stewardship. So we looked at, because the VA is an integrated healthcare system, we can look across the entire health system and determine where antibiotics are being prescribed. I think there's a lot of really interesting things we can talk about with this one table, but I'd like you to focus on the sections of the graph that are highlighted, of the table that are in purple boxes. So of all veterans that receive an outpatient medical visit, 18% receive at least one dose of an antibiotic. And over half of these antibiotics are broad-spectrum agents. And if you sum all of the individual prescriptions, the mean patient-level day supply is 24 days, almost a month of antibiotics. Now, if you look at dental visits, 16% of veterans receive at least one dose of an antibiotic, not that far off from medical visits. But broad-spectrum prescribing is relatively rare, and the patient-level mean day supply was over 11 days. Now, while this is not as big as what we see with medical care visits, it's still a lot longer than we thought. So I know many of you are interested in prescription-level data, so I have the numbers for the mean day supply for antibiotics prescribed from medical visits in the VA is 7.7 days. And for dental providers, it's 7.3 days. So again, not that different. So what do dentists prescribe? And this was an analysis led by Laura Koppen, who's faculty now in pharmacy practice. And she looked at dentist prescribing to Medicare Part D beneficiaries and found that almost 60% of all prescription medications prescribed to Part D beneficiaries were antibiotics. Again, amoxicillin overwhelmingly, followed by clindamycin. Opioids were about 20%, and benzodiazepines were only about less than 1.5%, so not that prevalent. Now, I think it's interesting that opioids are 20% because we also are working with someone who has access to the United Kingdom's National Healthcare Service database. And in the UK, dentists only, of all the medications prescribed by dentists in the UK, only 1% of all the medications they prescribe are for opioids. So quite a difference in practice in the United States by dentists. Oh, and before Simon asks me, this data is from 2014. So it's before hydrocodone was rescheduled. Hydrocodone and codeine were the majority of the opioids prescribed. But it's also after when benzodiazepines were covered by Medicare Part D. Benzodiazepines haven't always been available on the Part D formulary.
Can I ask you a question?
Mm-hmm.
Are dentists allowed to prescribe medical marijuana?
The question is, are dentists have prescribing privileges over medical marijuana? I think.
Explain the benzos being so low because they give everyone medical marijuana to chill before it's cured?
Perhaps, I'm not sure. I'll have to defer to my dentistry colleagues here. Although this is in 2014, Simon, when did medical marijuana, what year did medical marijuana, was it rolled out in some states? Probably later than 2014, right?
Yeah, no, good point.
Okay. But this is the public use file, so you could pull this and see if there's any trends.
Or we could just survey everyone.
We could survey. Okay. This is being recorded. So we also saw significant geographic variability. So the graph in the upper left-hand corner is In antibiotic prescriptions per 100 Part D beneficiaries, and this is, again, just for dentists. And we saw the highest prescribing rates in the western United States and actually the lowest in the southern United States. And this is very different from what you see in aggregated data from all providers, which is the graph in the bottom of this slide. So this is CDC data that is from the same year, from 2014. And the highest prescribing rate, again, similar to the paper that I presented to you earlier, was in the southern United States. Now, you could say, well, this is not visit-based information, so perhaps your denominator is biased. And I agree with you, although we don't have visit-based information for the Part D file that we used. But if we look at the VA, which is the blue graph, we see similar results with the highest visit-based prescribing rate in the western United States, although I think the lowest here was actually in the northeastern U.S. So what are some of our take-home messages from this paper? Well, dentists prescribe mainly antibiotics and opioids. We also found that the highest prescribing rates by dentists for antibiotics are discordant with all providers. And this is important because the CDC targets antibiotic stewardship efforts in those areas that have the highest prescribing rates. So those dentists that reside in high prescribing areas, high prescribing dental areas, are perhaps not getting some of these messaging for antibiotic stewardship. We also found, after adjusting for volume of the dentists, that 69% of the dentists in the highest quartile of opioid prescribers were also in the highest quartile of antibiotic prescribers. So perhaps overprescribing is not limited to one medication class. And if we targeted interventions to multiple classes, our interventions may be more effective as well as have a higher impact. But again, we don't know a lot about appropriateness of prescribing because we did not have any diagnostic information, any coding available to us. Oh, so this was the key piece of information that then angled me exactly where I needed to be for the R01. I started making connections with the College of Dentistry here, as well as other colleagues. And you've all heard us say multiple times that you need to identify a niche. And this was a niche that I thought was important to public health, funders would be interested in, and it was something that I was excited about and I could leverage myself for. So prior to this, I had been doing work looking at opioid prescribing in the VA as well. So I was uniquely qualified to do this analysis, except for my fear of going to the dentist. Okay, so we know very little about dentist prescribing. So enter my R01. My R01 was funded last year. We're currently early in study year 2. And I thought I'd share some preliminary results with you. So this was a cross-sectional analysis of 8.7 million adult dental visits in 2015. And we looked at medical diagnoses from 2009 until the date of the dental visit. And we used Truven, and I know all of you are familiar with Truven. Truven does have a dental domain, which I purchased as part of the R01. We define appropriate antibiotic prophylaxis consistent with guidelines. And in order for an antibiotic to be appropriate, 2 conditions had to be met. First, that the patient have a cardiac condition at high risk for infective endocarditis. And second, that the patient have a dental procedure that involves manipulation of the gingival tissue of the periapical region of the tooth, or there's perforation of the oral mucosa. And an example of this would be a tooth extraction, for example. And we define this according to dental procedure codes, which are called CDTs. And in the absence of cardiac conditions, antibiotic prophylaxis in patients with prosthetic joints were defined as inappropriate. So for some of you who went to school, your health professional school a long time ago, you were probably taught something a little bit different. But the guidelines for this started changing in 2013, so we used the updated guidelines for this analysis. So we found that 98% of the visits where there was a prescription for antibiotic prophylaxis did have gingival manipulation, but only 22% of those visits had a patient with one of these cardiac conditions. And therefore, 78% of all the antibiotic prophylaxis prescriptions were defined as unnecessary. So dentists are appropriately prescribing antibiotics for patients getting invasive dental procedures. However, they're not limiting those prescriptions to patients with cardiac conditions. So similar to the other data sets that I described earlier, amoxicillin was most frequently prescribed for antibiotic prophylaxis, followed by clindamycin. And 95% of the agents were appropriately selected. And again, this is very different from what we see with medical providers, where only half of antibiotics are appropriately selected, consistent with guidelines. On our multivariable analysis, we found that younger patients, women, patients with a prosthetic joint, and those undergoing tooth implant procedures had the highest odds for antibiotic overprescribing. We also saw geographic variability, with the Midwest, South, and the West having the highest odds of antibiotic overprescribing. Now, the West had the highest odds, and this finding has been somewhat intriguing to my infectious disease colleagues, because if you look at my antibiotic overprescribing work in the JAMA paper, as well as the work of others, the West almost always has the lowest overprescribing rates. So this is pretty interesting to most of my colleagues. So I also have a VA Merit Award to investigate VA dentists' prescribing of medications. So why is the VA interested in this work? Well, similar to almost anything else in the United States, VA is the largest provider of dental care in the United States. Also, in the private sector, so private sector meaning the dentist that you go to, dentists rarely use diagnostic codes or ICD codes and are reimbursed based on these dental procedure codes. But for the last 10 years, VA dentists use these diagnostic codes in addition to dental procedure codes. So you can more accurately assign a diagnosis with a prescription, and this is very important, especially when you're looking at antibiotic prescribing. There's also lots of data over a prolonged period of time, as well as veterans can get not only prescription medications dispensed at VA pharmacies under their copay, if they have a copay, but they can also get over-the-counter medications. And this is really important when you're assessing analgesic prescribing, right, because of NSAIDs, non-steroidal anti-inflammatory drugs. And the VA is also very interested in this space because there's mandatory VA policies on the implementation of antibiotic stewardship, as well as safe opioid prescribing practices. And the VA also has a history of implementing and testing interventions based on the evidence derived from their investigators. So both the R01 and the Merit Award are doing some qualitative work, and that's being led by Dr. Lisa Sharp. And we don't have any results yet to share with you, but I thought I would share a little bit of the background data that I used for the grants on perceptions of antibiotic prescribing by dental providers. And this was work that I collaborated with the Illinois Department of Health, where we surveyed dentists in the highest prescribing counties in Illinois. So we asked dentists, which of the following affect whether you would prescribe or recommend an antibiotic? And I was pleased to see that guidelines were the most frequently cited factor. However, the next most frequently cited factor was physician recommendation, and this was much more frequent than patient request. And of course, when you ask a similar question to medical providers, patient request for antibiotics is perceived to be a primary factor of why they sometimes overprescribe an antibiotic. But I think as we're looking forward to implementing antibiotic stewardship interventions focused on dental providers, this is something really important to keep in mind, because dentists are not only pressured to prescribe antibiotics from patients, but also from medical providers. We also asked, do you feel antibiotics are overprescribed in Illinois? And they said yes. but that they themselves rarely prescribe antibiotics more often than they should prescribe antibiotics. And again, this is something that we also see with medical providers, where they think that it's not their prescribing, you know, it's the person down the street, it's the practice next door, that it's the advanced practice providers that are over-prescribing antibiotics. So I thought I'd talk a little bit more about my other research and how I'm trying to impact multi-drug resistance. So I shared this slide with you earlier on what we can do to decrease multi-drug resistance, C. difficile, while improving antibiotic prescribing. So let's see how my research program is working to conduct surveillance, track antibiotic prescribing, test infection prevention strategies, as well as evaluate and implement antibiotic stewardship. So this slide shows my grants. Each grant is represented by a circle. There are some grants that are on this slide multiple times because they're cross-cutting, meaning they hit more than one area. The green circles indicate VA funding. The red circles indicate NIH or HRQ funding, and the blue circles indicate CDC funding. And Swetha is sitting here in the front row, probably having nightmares because she's on the majority of these grants. And I'm also part of two different research networks. The first is the VA CDC Infection Prevention Practice-Based Research Network, which is funded by the CDC. And the second is Combating Antimicrobial Resistance through Rapid Implementation of Available Guidelines and Evidence. And that is funded by the VA's Query program, which is the VA's Intramural Implementation Science program. I think it's really fun to be able to talk about all these different spaces and then to use some of this work in relationship to some other things that we're doing. So, for example, we have a big project looking at carbapenem-resistant Enterobacteriaceae, which is a multi-drug resistant organism where we have virtually no treatment options and is really a threat to our acute care and our long-term care facilities. But we've been able to leverage some of our work, especially surveying infection preventionists and laboratorians, than in some of our other health policy work. So that's been really fun. And I forgot what else I was going to say, but this slide is about $7 million in active research funding currently ongoing. And I want to say I'm not leading all of this work. I'm either co-PI, PI, or co-investigator. So I've written some high-impact papers. I have some grants. So what? Why is that a big deal? So I think, first of all, I've been able to use my research to assist in the implementation and evaluate the effectiveness of outpatient antibiotic stewardship programs. I mentioned I'm working with the Illinois Department of Health, but I'm also working with the co-directors of the Antimicrobial Stewardship Program here at UIH, including Dr. Alan Gross, who's here today, to implement simple interventions, actually, and to help him then assess the impact of those interventions, whether or not they're worthwhile. We also worked with Dr. Susan Rowan, who's also here, who's Associate Dean in the College of Dentistry, who's in charge of the clinical enterprise here at UIC to implement the first antibiotic stewardship program at a dental practice in the entire country. And again, that's been, I think, really rewarding to see them, see the College of Dentistry totally take just a small idea that we had to do this and run with it. My research has also impacted health policy. I talked about the expenditures work, but the CID paper has been quoted in the National Action Plan for Combating Antimicrobial Resistant Bacteria. And we worked to establish a national goal to decrease antibiotic prescribing, which was led by the CDC and the Pew Charitable Trust. This year, I was added to the Joint Commission to formulate antimicrobial stewardship standards. So in the near future, I think a lot of people will not be fond of me because there will be new standards coming. But that's been really interesting to work through that process with the Joint Commission. And to everyone's surprise, the American Dental Association has also asked me to speak and to be involved, and I'm currently serving as a guideline writing group. And then we work to establish research priorities for combating multi-drug resistant organisms. I've worked on some position statements for some various professional organizations. And then finally, we had a grassroots effort to establish an infectious disease education network. And this was based on a small research project we did to survey student pharmacists on their knowledge of infectious disease and antibiotic stewardship. And since then, it's really grown into collaborating on research projects, using my statistical expertise to help them evaluate the effectiveness of what they're doing, and test various teaching and learning interventions, not only within the pharmacy curriculum, but also for our postdoctoral trainees. And the reason, and we've also had some think tanks. So one of our first think tank papers has been published in the American Journal of Pharmaceutical Education, where we provide recommendations of what should be included in the pharmacy curriculum, because antibiotic stewardship is no longer a niche service. It's a standard of care, and it's mandated by CMS and the Joint Commission. So it's important that we teach all pharmacists to be antimicrobial stewards in our current curriculum. Unfortunately, the dean's not here, so he couldn't hear that. I was hoping he would be here. But I think Dr. Gross enjoyed that. So that's a little bit of my path to combine pharmacoepidemiology and my new love for dentistry to be a new trailblazer in this area of pharmacoepidemiology of dental prescribing. I'd like to acknowledge my collaborators. I've been really fortunate to work with all of these fantastic people. I think a lot of these people are currently in the room, as well as my VA collaborators who really span the country from East Coast to West Coast. And then, of course, my funders, the Agency for Healthcare Research and Quality, Health Services Research and Development in the VA, and the CDC. And I can now take any questions that you may have. Dr. Tichette.
So, Katie, you mentioned that part of the guidelines for prescribing antibiotics for dentists include prescribing to patients who have possible cardiac issues. And it kind of got me thinking about some of the issues that pharmacists face with prescribing, and that's that they may not have access to electronic medical records and other things. Also thinking about some of the work that you're doing, looking at what was it again? But some of the qualitative work that you're doing, about how dentists think that they're prescribing according to guidelines themselves, but they think everybody else is not prescribing the guidelines. Do you think some of that is that dentists may be thinking that they're prescribing to guidelines when they can't determine whether or not a patient is truly eligible and or should be getting antibiotic prescribing, and therefore prescribe to be safe?
Thanks for that question. So that's definitely a problem. So your question surrounds their acts. So a lot of when you go to the dentist, you're self-reporting your diagnoses, right? And whether or not you're accurately reporting those. And I think that I mentioned that, dentists have been left out of the loop as far as prescribing resources, but I think in general, oral health care has been left out of the loop in our healthcare system. It's primary care. Oral health is primary care. And none of us in this room would probably ever not have dental insurance, right? Most of us have it, or when you finish your graduate training, you'll have dental insurance. But for your children, you would probably always have dental. And that's not the case across the country. So in addition, we don't think of dentistry as part of primary care, even though, there's a saying in dentistry that it all starts with the mouth. What's the saying? It all starts in the mouth or something. It's been shown over and over again that people that have better oral hygiene have better overall health. And certain cardiac diseases, for example, have been associated with certain bacteria in certain patients' mouth because they have poor oral hygiene. So as a result, we don't integrate the dental health record with the medical record. Now, here at UIH, there's a little more of an opportunity to look at the medical record, but there's still two different systems. In addition, at the VA, you can do that. So but the dental record is an overlay within what we call CPRS in the VA, the overall electronic healthcare system, electronic medical record. So the VA dentists, in theory, have better access to the actual diagnoses versus patient self-report. So whether or not they know the guidelines versus they think the patient maybe has a cardiac condition but they can't confirm it, it is a problem that we've recognized in the private sector. And just talking to my own dentist about this, he says that, he frequently struggles as well with some of these issues. But he says, I just don't prescribe any antibiotics anymore because the evidence just doesn't show that there's any association.
Yeah, because there's an opportunity cost there. I mean, if they're going to confirm that a patient has a cardiac condition requiring prophylaxis or treatment, that takes a lot of time.
It does.
It's just easier to write the prescription.
It is easier to write the prescription. Mm-hmm. Rachel?
So thank you very much for the presentation. It's really interesting to see it all kind of come together. On the dentist work, I did have one question. Have you looked at, or do you have the ability in the data to look at dental specialties? So orthodontia, facial surgery, periodontics, things like that, to see if there's differential prescribing to guidelines based on specialty?
So the question was regarding looking within the specialty of dentistry. And in Truven, as you probably know, the provider specialty is frequently missing, so we're unable to do that. But in IQVIA, we can, and we've looked at general frequency of number of prescriptions for those specialties, but we haven't done any subsequent analyses. But we do plan to stratify our results by the dental specialties because we do anticipate there being differences because an oral and maxillofacial surgeon, for example, is going to do more invasive procedures than a general dentist, as well as those procedures will be much more painful. So comparing a specialist to a general dentist prescribing, especially for opioids, are apples and oranges.
It's also, I'd be curious to know their level of training on some of the newer guidelines versus somebody who just kind of practices.
That's a good point. Yeah, that's a good point. Yeah, thank you for that. We can definitely do that using IQVIA, so we have it to the 5-digit zip code level, actually. Yes?
Yeah, thank you for the lecture. It's a great speech and congratulations on the work. So I have a question on the general theoretical framework associating drug resistance and overprescribing because it's very hard to establish a temporal precedent, and treatment of multi-resistant drugs require a lot of antibiotics. How do you establish causality from moving?
So thanks, Jifeng. Jifeng is doing a lot of analyses for us recently and just sent me results late last night for us to present for him to present during the R01 meeting this afternoon. So the question was regarding establishing causality between actual antibiotic consumption and multi-drug resistance or resistance in general. And so it's not a causal, technically it's an association, all of the data that we see. But even if you do it in very strict conditions with animals or with isolates in the lab, you will see this continuous antibiotics exposure equals resistance. We don't have an exact amount of number of doses or duration. It does vary, and it also varies by class. And if you're using antibiotics as monotherapy or as combination synergistic therapy, a lot depends on pharmacodynamics and pharmacokinetics, so taking some of you way back and for the pharmacy students into their nightmares on PK/PD. It also depends on things like time above the MIC. I used to teach this, so I should be able to talk about this really well. Area under the curve and things like that. But we know that even if you decrease antibiotics, even at a single hospital, you will see decreases in bacterial resistance over time. So it's an association, and we all determine it to be causal, the vast majority of people. There's also been some mathematical modeling which has shown associations. Does that answer your question? So it's not an RCT. Yeah, it's not an RCT. Yes?
So I noticed for American politics trending towards universal health care, and I was wondering how that would impact antibiotics in general and for your research, because I would only assume that once people have access, like our disclaimer, I see a positive light in Medicare for all, but there might be a situation where like a lot more people have access to health care, and they'll come right away to the dentist, and that might cause an influx of more prescribed antibiotics just to get the patient off their hands at the moment. So where would you see your direction of research with that, and in general for the country?
So the question is regarding what happens if we have universal health care in this country, and basically increasing access to oral health care, I believe, and how that will impact prescribing. So I think that would be a fantastic grant. So I think you just established a body of work. You should join our PhD program. So we don't know. There is some data in, I believe it's Oregon, that had the natural experiments that did look at what happened when you increase access, but I believe that was only to medical care. I don't believe oral health care was part of that. We also have some early data from the Affordable Care Act that did show that those patients did cost a lot, right, because they didn't have a lot of access, but overall it was anticipated to decrease costs over time. I would anticipate initially, yes, there would be a lot of people going to the dentist, and especially people who don't have access to dentists probably have poor oral health than those patients who have had preventative oral health care for some time, such as I've always had dental care from my parents or my own policy. So would antibiotic prescribing increase? Perhaps. It depends on what exactly those patients would need done. The one area of health services research that's very developed in dentistry is access. So they've done a lot of work looking at the profession in general, what patients do have access, what geographic areas, and how does Medicare and Medicaid impact access, because patients with Medicare and Medicaid don't necessarily have dental. Depends on the state. Medicare doesn't cover dentistry at all, actually, except for the prescriptions. Thank you.